This is Dr. Howard Strassler presenting the E-Lecture on Posterior Composite Resins, Module D, Class 1 Preparations and Restorations. If you remember from our treatment planning and diagnosis and decision-making lecture, in terms of when do we intervene for occlusal pits and fissures, we're going to be intervening when we see carious lesions, whether they be a minimally isolated carious lesion or the carious lesion is more extensive. Certainly we'll be intervening when we see defective restorations as well. And so when we make our decision for the type of restoration and preparation we'll be doing, it'll be based upon the pathology that's there. For minimally isolated carious lesions, we'll be considering small, minimally invasive preparations, doing a preventive resin restoration. As the caries becomes more extensive into pits and fissures, we consider for the occlusal both composite and amalgam. For this lecture, we'll be looking at the preparation restoration designs for composite resin for the Class 1 generally occlusal composite resin. Our preparation design uses an instrumentation of a 245 burr or a 330 burr for our conventional Class 1 and Class 2 direct composite posterior preparations. Our guidelines for decision making really are based upon the extension of the caries and the pathology. It depends upon the defective restoration and its ability to be repaired or need to be replaced. For Class 2, our preparation may not necessarily look like an amalgam preparation, but we may be doing a proximal carious preparation for a Class 2 with a slot, or we may be using a facial approach. And keep in mind, patients will also come in wanting to have restorations that are amalgam replaced with white fillings with composites because they themselves want to achieve an aesthetic result. Because when you look in the posterior teeth, you can see in this circumstance to this patient, having these amalgams was not aesthetic to her. She was embarrassed she had these fillings and wanted them replaced with composite. The composites we've used, we'll be using in the clinic, are for Class 1s, typically we're using highly filled composites, nanohybrid composites, TPH3 aesthetics, our packable composite quicks. When we're doing preventive resin restorations, we're using virtuoso flowable as our preventive resin restorative material. And as we've mentioned in the past, pit and fissure sealant, we're using Delton as our pit and fissure sealant. Our preparation design for a Class 1 direct composite, and we're talking more of an amalgam replacement design, typically has a depth of 1.3 to 1.5 millimeters. It does not have to be into dentin for a posterior composite. As compared to an amalgam, we want to be half a millimeter into dentin. If we're doing a preventive resin restoration, a PRR, we have more rounded preparations. They're more site-specific. We're removing the carious lesion only, and where the caries stops, our preparation stops. We never bevel occlusal margins for Class 1s. Gingival margins are not beveled for our lingual extension of our OOL preparation. We're using an etch and rinse adhesive, and at depths that are in proximity to the pulp, within a 1 to 2 millimeters of the pulp, we're using resin-modified glass ionomer liners. We're always looking at occlusion, trying to keep margins away from wear facets, areas for potential risk of fracture of a cava surface margin of composite or of premature wear. So when we look at occlusal preparations, we can break them into several different categories. In the upper right-hand side, you're looking at small, minimally invasive preparations on the occlusal of the second permanent premolar. The mesial portion of the occlusal of the maxillary first molar, but more conventional preparations on the OL for the distal of the first molar and the occlusal of the second molar. Below you see we've taken out an amalgam from this OL preparation. You can see staining of this hard dentin that's stained due to the corrosion products of the amalgam. And we take out the entire amalgam and we leave the preparation based upon what was designed by the removal of the defective restoration. And so really one surface and two surface posterior restorations fall within three types. A routine preparation to remove the caries, where our extension and our outlines defined by the extent of the caries. More minimally invasive preparations, PRRs, preventive resin restorations, and replacement restorations of existing amalgam or composites that are defective. So our diagnosis for replacement will be based upon caries, recurrent caries, defects due to marginal ditching or fracture. We'll still be doing our dam placement and our preparation. The dam and isolation in the posterior is very critical for composite. And if you're not using the dental dam, in fact, you'll be putting those restorations at risk for premature failure. So our etch and adhesive technique is basically etch the enamel first, then etch the dentin. You'll have a total etching time of 15 seconds where you'll be placing the etchant using a cannula tip around the enamel margins, then filling up the entire preparation 15 seconds by the clock. You rinse it for 10 seconds with an air water spray or water. You dry the tooth off, keeping the enamel frosty white and dry, and you have a slightly glossy, moisturized dentin. You then apply your adhesive. Following the instructions for the adhesive, a dwell time of typically 5 seconds. Air evaporate off the solvent from the adhesive and air thin it, and then light cure it with the light at right angles to the occlusal surface, as close to the tooth as possible. And on larger preparations, you may need to have to place the light over the mesial separate from the distal. Certainly class 2s and MODs, 2-surface and 3-surface composites in the posterior are going to require multiple light curing, especially on molars. Premolars, generally the light centered on the tooth will be adequate. So the preventive resin restoration, here we're looking at a single tooth that's been isolated with the dam, and you can see site-specific caries on this tooth, where we don't have to prepare a conventional preparation, but only prepare those areas where the caries is present. And we'll look at an example of this with a case. Our preparations are be done with very small burrs, and here we're looking at a number 1 round burr. On the right-hand side, a 329 burr and a 330 burr, smaller burrs to do our preparation. We can also use flame-shaped diamonds on a high-speed handpiece with an air water spray. People have used air abrasion where they're sandblasting the enamel. And people have also used lasers. Keep in mind these are site-specific, minimally invasive preparations. Our preparation, once it's completed, that our restoration will be an etch and rinse adhesive with a flowable composite that will act as a restorative for the preparation and a sealant over the entire occlusal surface. So here we have a circumstance. Caries adjacent to the sealant on tooth number 12 and pit and fissure caries on number 14. We've actually made the diagnosis with a laser fluorescence device. We've gone in with very small burrs, and if you look at the preparations are very minimally invasive. If you look at the first molar, we've just gone in where the caries is present. In fact, when we went into the distal portion of the occlusal, we realized that the caries was extremely minimal. We can see some stain fissures, but no caries extending beyond that. We etch the enamel first and etch the dentin. 15 seconds of total etching, rinsing, the tooth of all the etchant for 10 seconds, picking up the etchant with the high velocity evacuator, the HVE, then drying the tooth to leave the enamel frosty in appearance and moisturizing the dentin, apply our adhesive, air evaporate off the solvent for the adhesive, air thin it, and then light cure for 20 seconds. So here we are etching. For 15 seconds of all the surfaces we'll be restoring. We then rinse it for 10 seconds and dry the surface off. We apply the adhesive using a microbrush. We air thin and evaporate off the solvent. In this case, we're light curing for 10 to 20 seconds depending upon the light that you're using. The light's going to be touching the occlusal surfaces of the teeth as close as possible and at right angles. The operator's wearing orange glasses, or they're using the orange shield to use the orange as a blue blocker of the blue wavelength light coming off the light emitting diodes, the chipset of the curing light. Once we've placed the adhesive and light cured it, we now do needle tip placement of the composite, of the flowable. We place it in such a way that it doesn't pool anywhere, but that it's covering onto the occlusal surfaces and the preparations. We then light cure it for 20 seconds. If there's any bubbles in the flowable, we tease it out with the microbrush. We're using flowable composites for a number of different circumstances. We're using it in very small conservative cavity preparations, our PRRs. We're using it as a first increment in the proximal box of a class 2, so that when we apply our composite to the proximal box, we're getting a sandwich effect. We don't light cure the flowable, but basically we're wetting that surface and that interface. We can use it to repair margins of existing composites where they fractured, but there's no evidence of caries, and we can just repair. We're using it as a liner to help control postoperative sensitivity and as a stress breaker. People are using flowables for veneer temporaries and for bonding porcelain veneers. Flowables have multiple uses in our practice. These are less viscous composite resins, less highly filled by weight, less wear resistant. So we've placed our flowable and we've light cured. We make sure that for the premolar, we're covering the entire occlusal surface. For the molar, we're overlapping the light, using it for 20 seconds on the mesial portion, then 20 seconds on the distal. After we remove the dental dam, we evaluate and we adjust the occlusion. Typically, we'll use articulating ribbon to mark the composite, make sure the patient's biting on other portions of their occlusion and not just on the flowable. Our adjustment can be done with a finishing burr or done with an abrasive polisher like the enhanced polishers. Here we're looking at a 5-year recall of these restorations, and you can see the sealant on number 13 is still successful for this patient. What about when you have frank caries, caries that's present? And for this case, we're going to actually mix and match our preparations depending upon the extent of the caries in the premolar, second premolar, first molar, and second molar. Our cavity preparation for the fissurotomies for the preventive resin are done with a very, very small burr. For our other portions of the preparation where the caries is more extensive, we can use our 245 burr. And so we have a mix on the first molar, both a preventive resin preparation and a conventional OL preparation. We etch the teeth for 15 seconds, the enamel and dentin simultaneously. We rinse and dry, as we've previously described, and then we apply our adhesive. In this case, we're using a 5th generation adhesive applied to the etched enamel and etched dentin. We air thin it, and then we light cure it. We then place our composite. In this case, we're using a packable composite for the conventional preparations. We're applying it in increments of no greater than 2 millimeters. We're pushing it and adapting it with a condenser, and we're light curing between each increment of the composite. The first increment is placed and white cured. The second increment is placed and white cured. Between increments, you'll notice when you white cure composite, it has a wet surface. That's the air-inhibited layer, the oxygen-inhibited layer of the composite. It allows our increments to bond together and be a homogeneous mass once they're both white cured. The adhesive also has a wet surface when applied. You don't wipe it off. Do not wipe off the wet surface. That wet surface of the adhesive for all classes of composite is our air-inhibited layer and allows us to have bondability between the adhesive interface and the restorative composite that we're placing. We place a flowable in our small, minimally invasive preventive resin preparations. Our finishing of the occlusal is done with finishing burrs, and then our enhanced polisher. Here we're using a cup shape with no polishing paste. We only need to get posterior composites smooth. We don't need to get them to be lustrous. The patient has to be able to sense that it's smooth to their tongue. We don't need the extra step of using a polishing paste. Once we finish and polish the composite, we remove the dental dam and check the occlusion. After the occlusion's been adjusted, we then white cure the occlusal surface for an additional 20 to 30 seconds. Here we're looking at the preoperative view of with the dam applied on the occlusal and then the composites that have been placed. Or for this circumstance, here we're not dealing with caries, but rather we see amalgam restorations that have somewhat of a ditched margin, but what makes them unacceptable is the patient's unhappy with these gray looking fillings. We're replacing these amalgams because the patient wants an aesthetic change. Our preparation's done with adequate air water spray and a high-speed handpiece using a cross-cut fissure burr. All the amalgam is removed. For this case, we used a self-etch adhesive. And so the self-etch adhesive is applied for 10-second dwell time and agitated on the teeth. It's air thinned with air spray, air dried. We evaporate off the solvent and air thin, and we white cure the adhesive for 10 seconds. Since these are molars, we're going to be white curing the distal and the mesial so they overlap separately. And the same is true of the maxillary second molar where we're doing 2 increments. If you have a very wide light tip, you can cover the entire occlusal surface. In our clinics, our light tips are 7.5 millimeters in diameter. We apply our composite after the adhesive's been applied, and as long as the preparations are no greater than 2.2 millimeters in thickness, we can apply it in 1 increment. Keep in mind the C factor for these occlusals is a C factor of 5. If we're at a depth of 2.5 millimeters, I'm going to place these in 2 increments to give us stress release during polymerization shrinkage. I'm adapting the composite within the cavity preparation. In this case, I'm using a silicone-tipped instrument. The composite doesn't stick to the silicone tip. You can use your burnisher in your restorative cassette. I'd wet the burnisher with a little bit of adhesive. In fact, you can shape the composite with your PFI instruments, with your instruments, to form the anatomy that you want, similar to as if you were waxing. We light cure the composite, and then we go through our finishing. We want to finish this to have cusp ridges and some semblance of a buccal groove, lingual groove, and central fossa. In this case, I'm using a fine finishing diamond to accomplish that task, followed by a rubber abrasive composite polishing point. In this case, I'm using a different brand than what we have in the clinic. In the clinic, we'd be using our enhanced polishers. The enhanced polishers are run at 12,000 to 15,000 RPMs in order to accomplish their task. There's also a new semblance of instruments we can use for polishing composite, these diamond impregnated nylon polishing brushes. These work very nicely. We would go from the finishing burr directly to these finishing brushes. These brushes are very expensive. They're not available in the clinic, but you will see them when you get into private practice. In the upper left-hand corner, you can see the preoperative view and then the final placement of the two restorations on the occlusal surface of the maxillary first permanent and second permanent molars. For most routine-sized preparations, premolars, first molars, composite resin can be considered an amalgam substitute. We can use packable hybrid or micromatrix nanohybrid, nanofilled hybrid composites. Posterior composites, as you can see, requires a high level of attention to detail to achieve clinical success. The number of steps, the timing of the steps, the isolation of the teeth for placement of the composite. You've been viewing and listening to Posterior Composite Resins Module D, Class 1 Preparations and Restorations to include minimally invasive preventive resin restorations.